Hello, I bring greetings to all of you from Christian Medical College, Vellore. I will start with a scenario. Here is a 38-year-old male patient with past history of asthma and allergic rhinitis for 8 years. Lately, over last few months, his asthma has not been under good control on his usual ICS-LABA combination inhalers. His inhaler technique was checked, it was good. His asthma treatment was stepped up. The dose of inhaled corticosteroids were increased, but still his asthma was not under control and he ended up having frequent courses of oral steroids for exacerbations. And these exacerbations recur again after some time. The spirometry was done which showed persistent obstruction. He also developed a skin rash with some ulcerations. And now lately he has developed systemic symptoms like fever, malaise, weight loss. He was detected to have new onset of hypertension, and on further probing he has numbness of hands and legs. So clearly something more is happening more than his asthma or allergic rhinitis. So he was further evaluated, a blood count was done which showed normocytic normochromic anemia, and what was striking is peripheral eosinophilia with WBC counts of 15,800 with 30% eosinophils. IG was highly elevated, his renal function showed derangement and urine showed microscopic hematuria. So this is what the X-ray shows. It shows bilateral areas of ground glass opacities in mid and upper zones, and CT confirmed that he has multiple bilateral patchy areas of consolidation. So what happened to this patient? I will come to that later in part of my lecture. How to approach a patient who presented with respiratory symptoms and eosinophilia. So I will be talking about the role of eosinophils in health and disease, the classification of eosinophilic lung diseases, clinical features, the diagnosis, and how to approach a patient presenting with pulmonary eosinophilia. Eosinophil, what does the word eosinophil means? It has an affinity to acid stain or eosin stain, and it stains bright red when stained with Romanowsky stain. So that's from the word eosinophil comes as opposed to basophil. It's a two-lobed polymorphonuclear leukocyte 12 to 15 micrometer in diameter, and it originates from CD34 positive myeloid progenitor cells of bone marrow, and its differentiation is stimulated by cytokines like IL-3, IL-5 and GM-CSF. Eosinophil in normal health is actually a friend. It circulates in the peripheral blood for less than 18 hours and it reaches the tissue. It has an affinity to tissues with mucous membrane environment interaction like respiratory epithelium and gastrointestinal tract epithelium, and it migrates there by chemotaxis where it can remain for 8 to 12 days. In the cytoplasm of the eosinophil, there are granules, and these granules have cytokines. Some of the important cytokines are major basic protein, eosinophil cationic protein, eosinophil peroxidase, and eosinophil derived neurotoxin. And when stimulated, these granules are released by a process called degranulation, and these cytokines are toxic to parasites and tumor cells. So in normal health, eosinophils act against the parasites and the tumor cells. But when these cytokines are released excessively, this friend turns into a foe, and that's what causes eosinophil induced tissue damage. What is normal level of peripheral eosinophils? 50 to 250 per micrometer of blood, or 2 to 6%. In bronchial lavage, rather than using absolute numbers, we use percentages. In normal bronchoalveolar lavage, the percentage of eosinophil is less than 1%. Coming to the classification of eosinophil lung diseases, it can be classified as primary and secondary depending on whether you have an obvious cause for eosinophilia or not. Among primary eosinophilic lung diseases, you have simple pulmonary eosinophilia, acute eosinophilic pneumonia, chronic eosinophilic pneumonia, bronchocentric granulomatosis, idiopathic hypereosinophilic syndrome, and EGPA. In secondary pulmonary eosinophilia, it can be drug induced, parasite induced, or fungal induced. Other conditions can be rarely associated with mild to moderate eosinophilia. These include idiopathic pulmonary fibrosis, hypersensitive pneumonitis, Langerhans cell granulomatosis, sarcoidosis malignancy, and BOOP. And these groups are not primarily eosinophilic lung disease, but occasionally eosinophilia can be found. In BAL, you can have severe bronchoalveolar lavage eosinophilia, more than 30%, and these can be found in conditions like acute and chronic eosinophilic pneumonia and tropical pulmonary eosinophilia. In other conditions, you can have mild to moderate pulmonary eosinophilia in bronchoalveolar lavage, and these include IPF, sarcoidosis, pulmonary Langerhans cell histiocytosis, and connective tissue disorder related lung disease. Classification of eosinophilic lung disease can also be based on the site of involvement. It can be predominantly airway involvement or lung parenchymal involvement. In airway involvement, it can be asthma, it can be allergic bronchopulmonary aspergillosis, or bronchocentric granulomatosis. In lung parenchymal disorders can be often with non-systemic illness like infections, parasites, or fungal, hypereosinophilic syndromes, EGPA, drug reactions, and lymphoma. With no systemic involvement or cause, it can be idiopathic in simple eosinophilic pneumonia and acute and chronic eosinophilic pneumonia. Coming to asthma, asthma is not primarily a eosinophilic pulmonary disorder, but in the pathogenesis asthma, eosinophil plays a very important role. Mild peripheral eosinophilia is often noticed, and up to 800 per cubic millimeter eosinophils can be present in peripheral blood. Eosinophilic major basic protein, when it is released by degranulation, causes airway shedding, and this may contribute to the Crayola bodies which are sometimes found in the sputum of asthmatics. Allergic bronchopulmonary aspergillosis is an eosinophilic lung disorder. I won't be talking about it because there is a separate session on ABPA. Bronchocentric granulomatosis is a rare condition. There is an inflammatory and destructive process which starts from the bronchioles and it further extends into the surrounding parenchyma in a peribronchiolar fashion. And these patients present in two different ways. 1/3 of the patients are younger. They present with respiratory symptoms. They have history of asthma, peripheral eosinophilia. On tissue biopsy, aspergillus can be demonstrated as well as tissue eosinophilia. In 2/3 of the patients, they belong to the older age group. They present with non-specific symptoms. They don't have history of asthma or eosinophilia, and the tissue biopsy shows neutrophilia, and fungus cannot be demonstrated in them. The etiology of bronchocentric granulomatosis is not clear in majority of the cases. There has been association with mycobacterial and fungal infections, rheumatological disease, EGPA, and chronic granulomatous disease. Radiologically, it can present at masses, alveolar opacities, pneumonic consolidation, reticuloannular opacities which predominate in the upper lobes. Surgical biopsy is often required to make a confident diagnosis, and it shows peribronchial and peribronchiolar necrotizing eosinophilic granulomatous inflammation. The inflammation may be neutrophilic if they are of the older age group. Treatment is focused on the underlying or associated condition, and many patients improve spontaneously. The response to steroid is excellent. The next important condition is the tropical pulmonary eosinophilia. It is common in endemic countries, and India is an endemic country for tropical pulmonary eosinophilia. It commonly occurs in second to third decade, more common in males. The patients typically present with nocturnal cough, which does not go away with the usual medicines. Patients can also present like an asthma with shortness of breath and wheeze. They can have systemic symptoms like loss of appetite and fever. And usually, majority of the cases do not have clinical features of lymphatic filariasis. In fact, tropical pulmonary eosinophilia develops in less than 0.5% of patients with lymphatic filariasis. Why is that so? It's not very clear. It is caused by the circulating microfilaria, Wuchereria bancrofti and Bruguier-Mallet, when they get trapped in the lung parenchyma, the small blood vessels of the lung parenchyma. And when they get trapped, they release their antigenic contents, and it causes very intense eosinophilic inflammatory reaction. And at that time, microfilaria are usually not demonstrable in the peripheral blood. X-ray can be normal in 20 to 30% of the cases. It may show non-specific findings like prominent bronchovascular markings. There can be reticular nodular shadows. Miliary mottling, one of the important differential diagnoses of miliary mottling in tropical country like India is tropical pulmonary eosinophilia. Other findings like mediastinal lymphadenopathy and pleural effusions are rare manifestation. They have significant blood peripheral eosinophilia, more than 3000 per microliter of blood. There is ball eosinophilia, Ig levels are elevated. Raised anti-filarial IgG antibodies can be elevated. PFT typically shows restriction, and sometimes there can be a combination of restriction and obstruction in spirometry. The diagnostic criteria for tropical pulmonary eosinophilia, there are 4 criteria. One is the nocturnal cough, second is residence in filarial endemic area, eosinophil count more than 3300 cells per cubic millimeter of blood, and clinical and hematological response to diethyl carbamazine. So once you have a strong clinical suspicion, you don't have any other obvious cause for peripheral eosinophilia, it's all right to give an empirical treatment for the patient and to assess the response. And if the patient responds, then the diagnosis is tropical pulmonary eosinophilia. Drug of choice, diethyl carbamazine, 2 mg per kg 3 times a day for 3 weeks. The role of steroids is not very clear. In majority of the patients, they improve with diethyl carbamazine. So there is, unless the patient is very symptomatic, you can avoid steroids. The response is dramatic. If the treatment is delayed, there can be progressive interstitial fibrosis and irreversible reduction in lung function can occur. Relapses are common. Up to 20% of the patients relapse in the first 5 years, and the retreatment with diethyl carbamazine, these patients respond very well. Coming to the drug reactions, drugs are a very important cause of eosinophilia, and a thorough drug history has to be taken to rule out this as the cause. Some of the examples are nitrofurantoin, sulfasalazine, phenytoin, bleomycin, and tetracycline. And the treatment is discontinuation of the drug. If the patient is severely symptomatic, you can give a short course of systemic steroids. There is a specific condition or syndrome called DRESS syndrome, drug reaction with eosinophilia and systemic symptoms. A number of agents are implicated. Some of the examples are allopurinol, antiepileptic, sulfasalazine, vancomycin, minocycline. And these patients present with systemic symptoms like skin eruptions, fever, facial edema, and enlarged lymph nodes. A minority of them can have respiratory symptoms. The next condition is the Loeffler syndrome, otherwise called simple pulmonary eosinophilia. Any age group can be affected by this condition, and it is usually self-limiting. The patient present with self-limiting respiratory symptoms which last for a few days and weeks, and then patients recover spontaneously. They have moderate to marked peripheral eosinophilia, and it is caused by the transpulmonary passage of the helminthic larvae. Ascaris lumbricoides is the most common larvae which is implicated. Other larvae like Ankylosoma duodenale, Necator americans and Strongyloides can also cause similar syndromes. The pulmonary function shows restrictive physiology, there is reduction in diffusion capacity, and we have to remember that stool examination when the patient is symptomatic with respiratory symptoms is usually normal. We will have to wait for at least 3 months before we can demonstrate the parasites in the stool. Treatment is basically symptomatic because it's self-limiting. You can treat with bronchodilators. There is doubtful role for steroids. The role of mebendazole is to treat the intestinal infestation. Strongyloidosis is an important larvae which can cause pulmonary eosinophilia. Specifically, this needs mention because it can cause a range of clinical manifestation from asymptomatic pulmonary eosinophilia to a self-limiting Loeffler's-like syndrome to debilitating condition called chronic autoinfection or disseminated strongyloidosis infection. The peculiarity about this larvae is that it can cause autoinfection. The rhabditiform larvae can mature, can change into the filariform larvae in the same host, in the GA of the same host, and this filariform larvae can can penetrate the mucosa and re-enter the bloodstream, and then that perpetuates a cycle of autoinfection causing what is called hyperinfection syndrome. And this is more common in those with defective cell-mediated immunity. It's also common in individuals with diverticulosis and reduced GI mobility. So in such individuals, this causes autoinfection and hyperinfection, and that can be, if it is not detected and treated, it can be fatal. And it is important to remember that this is the only condition of eosinophilic lung diseases which worsens with steroid. So steroid is commonly used. You don't have a diagnosis, you just jump and give steroids. Steroids are very effective in killing the eosinophils, but not in this condition. You are going to cause this patient to deteriorate further and further, and patient may eventually succumb to this disease. Stool examination is notoriously insensitive to detecting the strongyloidosis larva, less than 50% sensitivity. But in disseminated strongyloidosis, filariform larvae can be found in stool, sputum, bronchial lavage, and pleural fluid. Testing for IgG antibodies by ELISA can also be used for diagnosis of strongyloidosis infection. Sometime back, we had a patient undergoing chemotherapy for hematological malignancy. He had a lung infiltrate and bronchoalveolar lavage was done for the patient. And we sent the lavage fluid to the microbiology lab, and we got a phone call from the microbiologist. See, I am looking something funny in the microscope. Come on and see. And we rushed, and this is what we saw. The alive worms of the strongyloidosis larva. And this patient was subsequently treated, and then he recovered well. Ivermectin is the drug of choice. 2 single 200 microgram per kg doses administered on 2 consecutive days. If it is disseminated infection, you need to treat for 5 to 7 days. Albendazole is the next alternative. The next condition is chronic eosinophilic pneumonia. The peak incidence is in the 50s. It's more common in females. more common in non-smokers as compared to smokers. This is one of the few conditions which is less common in smokers, chronic eosinophilic pneumonia. The patients present with respiratory symptoms like cough, fever, shortness of breath. They can have weight loss. Antecedent or present history of asthma is present in about half of the patients. They have, majority of them, more than 88% of them have peripheral eosinophilia, and they have ball eosinophilia as well. The typical chest X-ray feature of a chronic eosinophilic pneumonia is what is called photographic negative of pulmonary edema. That means there is diffuse peripherally based infiltrates involving the outer 2/3 of the lung fields. And it is important to note that this typical picture of photographic negative pulmonary edema is found only in less than 1/3 of the patient. So, if your patient does not have this typical X-ray picture, don't think that okay, there is some other condition, chronic eosinophilic pneumonia is ruled out. No, it's not so. IgE is significantly elevated. There is non-specific elevation of ESR, rheumatoid factor, immune complexes and platelet count in this condition, and PFT will show mild restrictive physiology. Unlike simple eosinophilic pneumonia, spontaneous resolution is rare, so you need to treat it, and treatment it with steroids 40 mg prednisolone per day, and there is dramatic improvement of symptoms within 1 or 2 days, and X-ray shows clearance in 10 days. Relapses are common in the first 6 months, and the treatment is again with steroids. Acute eosinophilic pneumonia is the next condition, and it presents with an acute febrile illness of less than 5 days duration. There is some association with recent smoking, and less commonly with heavy inhalation exposure to dust, fine sand and smoke. The patient can progress rapidly to hypoxic respiratory failure and acute respiratory distress syndrome. The peripheral eosinophilia is absent. So, you have to have high index of suspicion. If a patient with ARDS in your ICU does not have any other signs or symptoms suggestive of an infection, there is no antecedent risk factor for ARDS, then your index of suspicion for acute eosinophilic pneumonia should be high, because this can be diagnosed only if you do a bronchoscopy and bronchoalveolar lavage, and lavage fluid will show high eosinophil count more than 25%. The X-ray will show diffuse alveolar or mixed infiltrates. There is no specific feature, it just looks like ARDS. The bronchoalveolar lavage helps also to rule out other bacterial, parasitic, fungal infections. And one thing specifically we should remember and raise our index of suspicion is multi-organ failure usually does not occur. So, patient has severe ARDS, all other systems are fine, then you should consider this as one of the differential diagnoses. The treatment is with steroids, and there is prompt and complete response to systemic steroids. Hypereosinophilic syndrome is another important entity. It's a group of disorders marked by sustained overproduction of eosinophils. We need to remember two terminologies here, hypereosinophilia and hypereosinophilic syndrome. When do you say that the patient has hypereosinophilia? When the absolute eosinophil count is more than 1500 cells per cubic microliter of blood on 2 examinations separated in time by at least 1 month. So, this is in contrast to the earlier definition in which they suggested that you have to demonstrate this persistent eosinophilia for 6 months. Now, in the recent definition it has been reduced to 1 month, and this hypereosinophilia in the peripheral blood should be associated with and or pathological confirmation of tissue hypereosinophilia. How will you define tissue eosinophilia? If you have done a bone marrow, the bone marrow should have more than 20% of eosinophils. Hypereosinophilic syndrome is defined as hypereosinophilia with eosinophil mediated organ dysfunction or damage, provided other potential causes have been ruled out. So, in hypereosinophilia, there is elevation of eosinophil count in the peripheral blood and or in the tissue. In hypereosinophilic syndrome, there is in addition organ dysfunction or damage. How will you categorize hypereosinophilic syndrome? It is a group of disorders. It can be primary or secondary. Primary means it can have a neoplastic etiology. There is eosinophilic expansion. It occurs in a setting of an underlying stem cell, myeloid or eosinophilic cytoneoplasm, and it is considered or proven clonal. The next category is secondary or reactive hypereosinophilic syndrome. Here there is no clonal expansion. There is eosinophilic expansion. The eosinophilic expansion is driven by eosinophilopoietic cytokines like IL-5, and it is considered polyclonal. There is some other driving factor for hypereosinophilia. Examples include parasitic infection, solid tumors, T-cell lymphoma, and it is polyclonal in origin as compared to clonal in origin in the primary hypereosinophilic syndrome. The next third category is you do not have either of these, you cannot prove either of these, it is idiopathic. Up to 75% of hypereosinophilic syndrome, it is idiopathic. There are variants of hypereosinophilic syndrome. The first one is the myeloproliferative HES, which can be due to mutations. For example, it can be due to mutations in platelet-derived growth factor receptor alpha or beta, fibroblastic growth factor receptor rearrangements, JAK2 mutations, or chronic eosinophilic pneumonia, chronic eosinophilic leukemia. T-cell lymphocytic HES can occur, familiar and organ-restricted HES can also occur. In fact, some people say that the organ-restricted hypereosinophilic syndrome can include conditions like chronic eosinophilic pneumonia or eosinophilic GI disorders as well. Things are not very clear about that. How do the patients present? They present with dermatological manifestation like skin rash in 37% of cases. There can be pulmonary manifestations with cough and breathlessness in 25%. GI symptoms like hepatosplenomegaly in 14%. Cardiac involvement can occur, and this is one of the common causes of mortality. Patients can have neurological manifestation like encephalopathy or peripheral neuropathy. Venous or arterial thrombosis can also occur. It is hypereosinophilic syndrome is most common in patients 20 to 50 years of age, and patients with FIP like platelet-derived growth factor receptor alpha mutation commonly affects male. How will you work up a patient? You need to do thorough blood chemistries, ECG and echocardiogram because cardiac involvement causes mortality, pulmonary function test, whole body CT scan to find out any neoplasm, tissue biopsies and additional studies as clinically indicated. Bone marrow aspiration and biopsy should be done, and this biopsy specimen has to be sent for immunohistochemical studies and molecular analysis for mutations. How do you make a diagnosis? You have to exclude other causes of hypereosinophilia, and you need to test the tissue samples for molecular gene mutations. Cytogenetics and T-cell marker studies also needs to be done on the biopsy samples. Treatment is of the underlying cause which caused the hypereosinophilic syndrome. It can be chemotherapy. Short-term glucose corticosteroids may be necessary to accelerate resolution, but importantly we need to remember again that stronger low doses should be ruled out. The next important condition is the eosinophilic granulomatosis with polyangiitis, otherwise called EGPA. It was first described by Chrug and Strauss in 1951, and for decades till recently it has been called the Chrug-Strauss syndrome. And in between it was called as allergic angiitis and granulomatosis. Now the accepted terminology is EGPA, eosinophilic granulomatosis with polyangiitis. The patients progress through 3 different phases. For years, the patients may present only as asthma and allergic rhinitis. But just like our index case which I described at the beginning, the asthma gets out of control and there is dramatic peripheral eosinophilia. And at this point, there is tissue infiltration by eosinophils. And in the last stage, there is systemic vasculitis involving multiple organs and end organ dysfunction occurs. ANCA, anti-nuclear cytoplasmic antigen, can be positive in 40 to 60% of cases. So, absence of ANCA does not rule out EGPA, we need to remember that. And what type of ANCAs are present in these individuals? It is myeloperoxidase positive, or the staining is of perinucleolar pattern in 70 to 75% of cases. There is some association of EGPA with leukotriene antagonists like montelukast, and probably it is only coincidental and not causative. It is coincidental with steroid tapering of primary eosinophilic infiltrative disorder. So, once you start montelukast, you start tapering the systemic steroid with the patient is on, and then the EGPA manifests. How do you diagnose EGPA? There is an American College of Rheumatology criteria which include asthma, which is often poorly controlled, and greater than 10% peripheral eosinophils. Patients can have mononeuropathy including multiplex or polyneuropathy. There is migratory or transient pulmonary opacities on chest radiograph, paranasal sinus abnormality, and biopsy containing a blood vessel showing the accumulation of eosinophils in extravascular areas. So, if the patient satisfies all these criteria, it has excellent sensitivity and specificity. EGPA patients can have a myriad of presentations. They can present with upper airway symptoms, skin manifestation, neurological manifestations, gastrointestinal manifestations, cardiac and renal. Chest X-ray may show transient and patchy opacities without lobar or segmental distribution. Pathological diagnosis is mandatory, and you can, depending on the organ involvement, you can biopsy either the skin or the peripheral nerve or kidney. TBLB cannot positively diagnose EGPA, but it is helpful in ruling out infections and alternative diagnosis. And more importantly, a bronchiolar lavage may demonstrate BAL eosinophilia. Open lung biopsy is the gold standard, but if you are able to achieve the diagnosis but other means like a skin biopsy, nerve or kidney biopsy, there is no need to do the open lung biopsy. So, in the index patient which I described initially, the nerve conduction studies has confirmed mononeuritis multiplex. Patient underwent a bronchiolar lavage which revealed intense BAL eosinophilia, and all the cultures for infections are negative. A kidney and a skin biopsy was performed, and which confirmed necrotizing giant cell vasculitis, small vessel with granulomas and eosinophils, and a diagnosis of EGPA was made for that patient. We need to consider a differential diagnosis for such patients. Wegener's granulomatosis is a vasculitis, but the presentation radiological manifestation is cavitating nodules in the lung. And more commonly, C-ANCA is positive. There is no eosinophilia in Wegener's granulomatosis, and the histology is different. In chronic eosinophilic pneumonia, there is no extrapulmonary manifestation like what occurs in EGPA, and there are no granulomas. In hypereosinophilic syndrome, there are no granulomas on biopsy, and there is no vasculitis. The treatment of EGPA is prednisolone, steroids, and the response is usually dramatic. And you need to give the treatment to 62 weeks, and depending on the response, you need to taper. If there is major organ involvement or the patient relapses or there is corticosteroid resistant cases, you need to give an additional immunosuppressive agent like azathioprine or cyclophosphamide. So how do you approach a patient presenting with pulmonary eosinophilia? You need to take a thorough history and do a detailed examination. Take a history of recent travel, drug intake, asthma history, and test the stool for parasites. That's the initial steps. And then you do spirometry and find out whether the patient have obstructive spirometry or a restrictive physiology. If the patient has obstructive physiology, you look for non-pulmonary organ involvement. If it is there, it can suggest vasculitis like EGPA. If there is only pulmonary involvement and there is no other systemic involvement and the chest X-ray is normal and IG is not hugely elevated, then you consider the diagnosis of asthma. If the X-ray is abnormal, IG is highly elevated, you consider ABPA and bronchocentric granulomatosis. If the spirometry showed restriction, you need to do a bronchial lavage and test for ball eosinophilia. In addition, you test for parasites and fungus. And if the ball eosinophilia is only mild to moderate, less than 30%, then it may be other interstitial lung diseases. If there is significant ball eosinophilia, but there is no peripheral eosinophilia, then you may be dealing with a patient with acute eosinophilic pneumonia. But there is moderate peripheral eosinophilia, you may consider chronic eosinophilic pneumonia. If there is extrapulmonary involvement, then you consider conditions like EGPA and hypereosinophilic syndrome. So in conclusion, eosinophilic syndrome, pulmonary eosinophilic syndromes have varied causes and a intelligent and systematic workup is required for accurate diagnosis and proper treatment. And in majority of the cases, if you make a proper diagnosis, the prognosis is good. Thank you.